Hello, this is Kim Jong-il. Today, we will look at the cases of orthodontic treatment through extraction of the third molars. This patient is a 22-year-old female who visited the hospital as chief complaint of protrusive lips and crowding of the anterior teeth. The protrusive lips are not severe from the side view. You can see that the roots of the lower anterior teeth are short. The upper and lower third molars have already erupted. Let's look at the PA view. There is a slight difference between the left and right, but it is not so severe, and the shape of the lips is not bad. Let's look at the intraoral conditions of the upper and lower. In the mandible, it can be seen that the first molar is inclined to the lingual side as the third molar erupt. In the maxillary, there is no posterior crossbite. The right side of this patient shows a half-class 3 canine key, and the left side shows a class 1 canine key. The lower midline is slightly deviated to the left. This seems to be because the right side is half-class 3 canine key. The lower posterior teeth can be seen to be meshally inclined. In addition, some teeth in the premolar area show crossbite, but there is no crossbite in the molar area. The patient's AB to mandibular plane angle is 61.5 degrees. Is the palatal plane positive value or negative? Since ANS is going up, the palatal plane is a negative value. AB plane angle is a positive value because point A is located behind point B. ODI 56, APDI 89, and CF 146. The APDI value is greater than 85, so it is a class 3 malocclusion. Because CF is small, it is class 3 high angle. Looking at the E line, the lip doesn't protrude too much. However, because it is a class 3 malocclusion, U1 to FH is 124, which means labioversion. Because the upper incisor is proclined, the patient can think of it as a protrusive lips. IMPA is 92 degrees, which is normal, and IIA is 119 degrees. UOP and POP are slightly flat. Let's look at this patient's problem lists. To solve the protrusive lips, we need to extract some teeth. There is a possibility of extraction due to crowding of the anterior teeth. Habit control should be performed for the treatment of lateral open bite, and the posterior crossbite should be treated with non-extraction. If the third molar has already erupted, it must be extracted or maintained. Since the lower first molars are lingually inclined, non-extraction should be considered. This patient has short roots. If possible, it would be better to shorten the treatment period with non-extraction. Then, the only reason to consider extraction treatment is protrusive lips. There are many reasons for non-extraction, such as the posterior crossbite, the third molar eruption, the lingual inclined lower molar, and the short root, etc. However, the problem of treating this patient with non-extraction is that the protrusive lips are not resolved. Combination factor is small and U1 to FH is 124 degrees. What are the problems with extracting premolars? The roots will become shorter, the curve of Spee and the curve of Wilson will become more severe, and the posterior crossbite will worsen. If third molars are extracted, this patient loses a total of 8 teeth. The first thing you need to check in the diagnosis is whether there is crowding of the lower anterior teeth, and if so, how much. In this patient, the crowding of the lower incisor is mild, and the lingual inclination of the posterior teeth is observed. The profile is not bad. If the location of the third molar is not good, the upper and lower third molar should be extracted. The posterior available space distance from the ramus anterior border to the distal surface of the lower second molars is obtained. By extracting the upper and lower third molars, the posterior available space can be measured through Ceph and panorama. Therefore, if necessary, a third molar tooth will be extracted. At the time of diagnosis, explain facial asymmetry to the patient and extract the third molar tooth. Since it is an open bite case, it would be better to use a tongue crib retainer after treatment. How to treat it? The treatment plan may vary depending on whether you know the Mio technique or not. If you do not know the Mio technique, you will use a mini screw to move the lower anterior teeth posteriorly. However, it is difficult to put a mini screw on the lingual side of the lower. So if you put it on the buccal side and move it backward, the possibility of posterior crossbite increases. In that case, the upper arch can be expanded again using a mini screw to resolve the posterior crossbite. However, once you know the Mio technique, treatment is possible without using a mini screw or MARPI. The treatment method of the Mio technique is largely divided into strategic leveling and the use of Mio wires at the finishing stage. When doing a diagnosis, first check if there is crossbite on the terminal molar. This patient has no crossbite on the terminal molar. So strategic leveling is required immediately. In the case of Class 3 malocclusion treatment, let's think about the bracket system again. Many doctors use SWA brackets. The SWA brackets already have crown labial torque in the maxillary incisors and crown lingual torque in the mandible. Which tooth movement is good for Class 3 treatment among A and B? The tooth movement in Figure A is tipping of the tooth. The tooth movement in Figure B shows the bodily movement translation. Of course, it would be better to move like B. So, I recommend the Kim's bracket. I made a decision to treat this patient with non-extraction. And Kim's bracket, which has a 0 degree, was used for all teeth. Next is strategic bonding. First, check the long axis of the tooth and evaluate if brackets can be bonded on the right position. Brackets were not attached to the upper and lower first molars at first. I checked whether the bracket can be put in the right position from tooth 15 to tooth 25. Tooth 42 is slightly rotated, but bracket can be attached in the right position. Tooth 35 is also slightly rotated, but bracket can be attached in the right position. Therefore, attach the brackets to teeth 1, 2, 3, 4, 5, and 7 for upper and lower. Initially, it is advisable not to attach a bracket to the tooth in front of terminal molar. Then, in 016 NITI, use an open coil spring on the first molar area. After that, you can attach the bracket to the first molar and insert the Mio wire into the lower arch. At this point, the puttee elastics from first loop of the lower mu to the upper canine. When using this Class 3 elastic, the upper incisors may become labioversion. So I use the Kim's bracket for upper to minimize the labioversion of the upper incisors and adjust it with Mio wire at the finishing stage. Above picture is an X-ray before treatment, and the third molar was extracted during the leveling stage. You can see that the third molar was extracted and the second molar was uprighted. Bottom X-ray was taken as soon as the bracket was attached, so you can see that the uprighting of the first molar is a bit insufficient. But this can be improved by using Mio wire. Let's look at how the teeth move before treatment and after leveling stage. The lower incisors may be slightly labioversion. The important thing is to keep the position of upper incisors as possible as it is now. Therefore, a 0-degree bracket is used, and an additional crown lingual torque of -7 degrees is applied to the upper incisors of upper meo wire, in order to minimize the protrusion of the upper incisors at the finishing stage. Meo arch wire with crown labial plus 7 degrees torque in lower incisors is used. The midline is slightly deviated to the left, so on the right side, use elastics from upper second loop to the lower first loop. And on the left, use elastics from upper first loop to lower first loop. Then the canine key will be class 1. Then, put elastics from the first loop of the upper to the first loop of the lower to create an appropriate OB relationship, and the treatment is finished. The Meo treatment process is relatively simple. For strategic leveling, don't attach a bracket to the teeth in front of terminal molar, use OCS on tooth 6 area, and then attach a bracket to tooth 6. And leveling teeth, use Meo for upper and lower in finishing stage. You can see the meshily inclined lower posterior teeth has been uprighted. Also, the short roots of the lower were not worsened. Looking at the front picture, the patient got a desirable smile line. The treatment period took 9 months. What I emphasize in Meo orthodontic is that the combination factor hardly changes. The initial CF was 146, and CF after treatment was 144. U1 to FH124 has been slightly improved to 120 degrees. Class 3 elastic was used, but U1 was no longer labioversion. In lower arch, the space was acquired while L1 maintained the initial position. The CEFs before and after treatment were superimposed. As the upper and lower anterior teeth and posterior teeth were moved little by little, the total arch were changed. Let's look at this superimposition. In the superposition of the pre-treatment and the strategic leveling stage, the upper incisors were in place and the lower incisors were slightly labioversion. For the upper and lower incisors, a Kim's bracket 0-degree torque applied were used. In the last, Meo wire was used. And to improve class 3 relationship, short class 3 elastics was used. If you use short class 3 elastics, upper incisors are labioversion. To compensate for this, in the upper Meo, crown lingual torque is applied to the anterior part, and a curve of SPI is applied to the posterior part. In the lower Meo, crown labial torque is applied to the anterior part, and a reverse curve is applied to the posterior part. By using short class 3 elastics and anterior vertical elastics, the lower anterior teeth were moved posteriorly, the upper posterior teeth were intruded, and the upper anterior teeth were extruded. In Meo orthodontics, as previously lectured, the upper posterior teeth were extruded and became a class 3 malocclusion. So the upper molars should be intruded. Many doctors use mini screw to do intrusion, but in Meo treatment, strategic leveling and Meo wires are used. You can see a better profile by looking at the side and front views before and after treatment. Non-extraction treatment is possible by improving the arch form that is narrowed or constricted. Particularly in the lower, it is possible to move the lower, mesially inclined or mesially rotated lower molars posteriorly by extracting the third molars. These are in intraoral pictures before and after treatment. Good occlusion can be seen. Let's look at the whole treatment process. For strategic leveling, do not attach brackets to the upper and lower first molars. And attach brackets to teeth 1, 2, 3, 4, 5, and 7. Use an open coil spring on the first molar area. Then attach the bracket to the first molar and re-leveling. Insert the Meo with torque, applied to the upper and lower, and use elastics. Therefore, the Meo technique consists of strategic bonding, leveling, and finishing with Meo. In general, it takes 3 or 4 months to finish after inserting the meal wire. It is possible to shorten the treatment period by improving the anterior crowding and uprighting of lower molar and derotation through strategic bonding and leveling. Thank you for watching.